My talk is going to be what's on the street and what's in your ED. And I'll go a little more into detail exactly what that means. But first off, no financial disclosures. This is a link to the handout for the talk. I like people to just kind of sit back and relax and watch the talk and not have to write down notes. So this handout actually has everything I'm going to talk about. It also has all of my references and contact information. So again, what's in the street and what's in your ED? This could be a whole host of different things, but what we're going to focus on are some of the less common, specifically designer drugs that you may see patients using in the street and then coming into your emergency department. So we'll start with a quick case. This is your patient that comes in. He's mid-30s gentleman coming in by EMS, and this is kind of what he looks like on the stretcher when he comes in. He's fairly somnolent. He has a fairly normal BP, heart rate a little bradycardic, respiratory rate a little bit slow. You don't really know what happened, but he's altered, and you have a story that he's maybe having a good time out in the streets. So you go ahead and give him some Narcan IM to see what happens. Well, this kind of changes the scenery pretty quick. He gets pretty aggressive. He gets combative. He's yelling at your nurses. He gets up pretty fast. So you have some thought there may be a narcotic component as to what's going on. So like a good doctor, you give him a nice dose of 500 milligrams of ketamine IM, and that kind of puts him back down. So this kid's sketchy crew of friends decides to come in the emergency department and kind of give you some more insight as to what might be going on. And what they tell you is that their boy bought this from a head shop a few years ago and hand you kind of a nondescript package. You see, it's just that foil packet. It says not for human consumption. That's really all you know. There's nothing in it, but you know he supposedly bought it legally from a store a few years back, if you trust what these individuals are telling you. So you start to think, what could be going on with this patient? Well, probably the most important thing they told you is that he was actually able to purchase this substance from a shop. And so what that makes you think of are what were sometimes called legal highs. And the reason I say sometimes called legal highs is because this is an ever-changing field as to what's legal and what's illegal. I lectured on this probably 4 or 5 years ago. And at that point, most of these were considered legal highs because what they were designer drugs that were either labeled as research use or not for human consumption or plant food, and were then able to be sold in shops and convenience stores and head shops. Since then, some states have actually put these on the schedule of illegal substances, and it's kind of an ever-changing environment. So it's not really important to try to memorize what's legal and what's illegal. But we can kind of combine these into a group of designer drugs. And we're going to specifically talk about 5 of them today, kind of the more common ones you see coming in from the street. And the ones we'll cover are synthetic cannabinoids, methoxetamine, cathinones, kratom, and salvia. And after speaking about each one and working through each substance, we'll kind of try to figure out what exactly our patient may have taken. So I'm also going to show some videos from a site called Drugs Lab. It's actually a YouTube channel, and it's a bunch of Dutchies from the Netherlands taking these substances and recording themselves and talking through their experiences. So not your usual thing to see in a lecture, but it is very insightful from a physician standpoint to actually have someone discussing what's going through their bodies and minds with these substances, even to the point where they have vital signs hooked up so you can actually see vital sign changes. So like I said, the first one we cover is synthetic cannabinoids, but Dr. Schimmel's actually going to cover this in the next talk. So I'm not going to ruin his thunder, and he probably knows a lot more about it than I do. So I'm going to let him discuss that. So kind of hold off on that. But I'll tell you, this patient, it was not a synthetic cannabinoid issue. So the one we'll talk about first is going to be methoxetamine, also known as MXE. And you see a picture over here, kind of a white powdery substance. Now, what you may guess from the name itself, it sounds a lot like ketamine, and it is. It's a derivative of ketamine, also similar to PCP. So from that, we can understand that the mechanism is going to be kind of an NMDA receptor agonist, or antagonist, I'm sorry. And it's going to cause kind of dissociative state that we often see in patients that we give ketamine to, or patients that may be coming in for taking PCP. Now, some basic information about the drug itself. As you can see in the package in the upper left, that's labeled MXE. This is how you'd find it in a store. Again, by the fact that it said research chemical and also said not for human consumption, at one point these were legal to sell in stores because of those labels. But you can see it could look like anything else. It could potentially look like candy. It could look like chewing tobacco. It looks like a very benign substance when it can actually have some pretty severe clinical effects. On the bottom left, we have the kind of powdery white substance. This can be taken many routes. It can be intranasal, it can be sublingual, injection, IM or IV. You can smoke it. The onset and duration are pretty similar to what we would see from ketamine, about 10 to 20 minutes onset, so a little bit longer, and then last a couple hours. The effects we may see in the hospital, we might see tachycardia, hypertension, hyperthermia. So again, when we give a patient ketamine, we expect they're going to get tachycardic and hyperthermic. What we also might see in the upper right is agitation, hallucinations, and dissociation. So these are things as a physician that might concern us that this patient is actually taking a substance. Again, fairly similar to ketamine, either with partial or full dissociation. On the bottom, the positive symptoms that patients are actually looking for by taking this are euphoria and a sense of calm. And the negative effects they may experience is distortion of reality, a loss of sensory perception. So all those things that any of us who use ketamine a fair amount, whether procedurally or for chemical restraint, we've kind of seen patients go through these positives and negatives. So in this video here, we're going to see the gentleman actually take MXE, and you can see that he's going to snort it. And on the left is a timer of how long it's going to take. I didn't put the audio in here because it's in Dutch, so it's hard to understand. But pretty soon you can see he's actually starting to dissociate. This is 37 minutes after insufflation. He's kind of in this weird trance state. He's still able to talk with the woman there. He's a little tachycardic, but he's just he's enjoying himself. He's having a sense of euphoria and kind of a distortion of reality. Probably the symptoms that he was hoping to get out of that substance. So that was methoxetamine. So next, let's go on to bath salts or the cathinones. Any of us who were practicing 5 years ago in emergency medicine probably saw this an unfortunate amount of times. This became a really big issue, especially alongside the synthetic cannabinoids. It seemed like at one point we were seeing this come in every day in the emergency department. So definitely something to talk about. Now, I do want to share kind of funny anecdote that actually 2 weeks ago, we were talking about bath salts in the emergency department. And one of the nurses says, I wonder who the first person was to eat bath salts and find out they make you high. And it's important to understand that these aren't the bath salts that we use in the bath. A lot of people think it's the same thing, and that just happens to be an adverse effect of bath salts. But the reason these are called bath salts, again, is to get by those regulatory issues. By calling them bath salts or plant food or other things like that, they're able to legally sell them in stores. So again, these aren't the same as the bath salts that you soak in a tub with. In general, these are synthetic forms of cathinone, which is derived from the cat plant, which is a native from the Horn of Africa. And these are stimulants. And you can crush up this plant and get the cathinone substance from it. But most of the ones that we saw coming in the last 5 or 10 years were actually synthetic forms and derivatives of this. And that was kind of the issue when it came to regulation, because they would essentially outlaw one of them, the chemical structures, and then someone would add a side chain onto it. And they outlaw that one, someone would add another side chain onto it. So then they had to kind of come up with analog laws saying that anything from this base structure is going to be illegal. But you can see this list right here is just a very short list of different substances that were considered bath salts. And based on each strain and each side branch, they had very different effects. So in general, bath salts will kind of show effects of kind of a trifecta of scary drugs that we see in the street: cocaine, methamphetamine, and MDMA, sorry. And so it's based on those side chains and those side branches as to what effects will show, and it may be all three of these effects. So we've all seen patients on these drugs, and to have all three of them showing themselves at once is kind of a pretty scary situation. So on the left, we see what bath salts may look like. Like I said, in that kind of canister, this is bath salts. They also may come in pill forms, may come in bags, but in general, most of them would say bath salts. On the bottom left, we see the white powder. So in the video that I'm going to show in a bit, the gentleman is actually going to insufflate it through his nose, but it can be smoked. It can be injected, many times taken in a pill form, almost like ecstasy. That'd be very common. And then also some cases of actually instilling it into the eyeball. The onset was about 20 to 30 minutes and lasts about 4 to 6 hours. Clinically, what we'd see vital signs wise, tachycardia, hypertension, hyperthermia, similar to MXE. Also combative self-mutilation, homicidality. So any of us who have seen these patients in the emergency department can tell they come in pretty combative. There are cases, there's that famous case in South Florida of the man who ate another man's face. I've seen patients coming in just in the throes of Hulkamania, just throwing security guards across the room. These patients can get pretty rough. The positive effects that the patients are looking for in taking these substances are increased alertness, euphoria, and sociability, and openness and talkativeness. So again, very similar to your party drugs, to your ecstasy. That's kind of the effects that people are hoping to get. In the video, again, we're seeing someone snort the bath salts, one of the ways you can take it. And then you can see he kind of starts getting an amphetamine effect. Now, I used the video for amphetamines because it didn't actually have a video for bath salts, but this is a very similar effect that you can see. You can see pretty quickly his heart rate's up to 188. He's kind of agitated in the video. If you see the subtitles, he's actually very uncomfortable and doesn't want them to keep filming because he's starting to get a little aggressive and agitated. But that's kind of a very common effect you may see with the bath salts. Moving on to our next one, salvia. So some of you may have seen this in the emergency department. I don't think we're seeing it too much, but you may be reading more about it in journals and the news as well. So it's actually from a plant, Salvia divinorum, and salvinorum A is the active chemical. So another plant-based substance that we're seeing. So many of these is kind of a mix. When you talk about these designer drugs, it's a mix of either a synthetic chemical or something that's actually derived from a plant. And the way this works is it actually activates the kappa opioid receptor. So we know about the mu opioid receptors and some of the other ones, but the kappa is a little bit different. It causes hallucinations, but it doesn't really cause like the respiratory depression that we see from our opioid activation. So it's that hallucination that people are actually taking the substance for. When we look at the information on it, it would come in small packages like that. It looks like a plant-like substance. It almost looks like a marijuana type substance. So that's where you could, if you have some of the substance brought in with the patient, you may be able to figure out what exactly they're taking. It can be smoked and also be chewed. The active ingredient is actually inactivated by stomach acids. So if someone were to just swallow it, it doesn't really work as well. So usually it's a chewing or a smoking that causes it to work. The interesting thing about this is the onset is within seconds and it only lasts minutes. So it'd actually be fairly unusual for us to see someone with the effects of these medications, because it should be over by the time they come in the department. In any videos you watch of patients taking this, it's pretty impressive to see how fast the effects actually come on. What we clinicians will see tachycardia, could see them in a hallucination state, disorientation, a little bit of giddiness. The reason they're taking it is to try to increase creativity, calm, and well-being, kind of have some introspection. They may have some side effects, obviously some dizziness, some fear or terror. Patients may not be used to taking substances and suddenly they don't have control of the environment around them. And so that may cause a sense of fear. Johns Hopkins actually did a study on this. They used 4 healthy patients that they said all had very extensive experience with psychedelics. And one of the quotes said, with salvia, the subjects described leaving this reality completely and going to other worlds or dimensions and interacting with entities. And that was a very powerful and intense experience. So you can imagine why patients would want to take this if they're trying to leave this current environment and maybe have better introspection or just kind of leave the world behind them for a little bit, especially with how short acting it is. But it's kind of interesting to read that paper and see actual scientific evidence on what patients are feeling. So in this video, we see the gentleman taking it. He's smoking it. And we'll see the effects actually last within a minute. He has the effects. And if in the video, he describes how every time he tries to put his hands out in front of him, it's like helium balloons lift them up. He can't hold his arms out in front of him because helium balloons keep lifting him up. And he goes on like this for a couple of minutes. And then within 5-10 minutes, the effects are gone. So again, a very interesting substance in the fact that it comes on within a minute and is gone within 5 to 10. And the last substance we'll talk about is kratom. So again, another one that I myself am hearing more about in the news and reading more about in journals and kind of seeing out in the community. So kratom, another plant-based medication or drug, it comes from Mitrianja, however you say that, Mitrianja speciosa. It's from the Southeast Asia, especially Thailand and Malaysia. Actually, the leaves of the plants, they're dried out and crushed to use. And the way this works, it works on a couple different receptors. It works on the mu and delta opioid receptors. Those ones have a common kind of narcotic response that we see from narcotic medications. And it also acts on the alpha-2 adrenergic receptor. which is going to be more of stimulant effects. So the interesting thing about this drug is that in very low doses, you get stimulant effects, what you'd expect from more kind of amphetamine medications. But as we go up in our dosing, we then get depressant effects. So it starts hitting those opioid receptors. So it's almost an interesting change in symptoms we see based on the dose that the patient takes. Again, it'll come in kind of very nice looking packages. Again, the Kratom right now is one of your more common ones to see in stores and head shops. A lot of the other ones I talked about before have been actually banned with legislation, but I feel like Kratom is kind of the next up and coming one that you'll walk into a head shop, or people can go into a legal marijuana store, and it'd be very common to see these nice bright packaging that looks like it's from any corporation that's putting out like a dietary supplement. Like I said, it is plant-based, so that's what it looks like in the bottom right or bottom left when it's crushed up. It looks like a very earthy, organic color. This can be taken many different ways. It can be chewed. It can be swallowed in a pill form like we saw before. It can be made into a tea. That's fairly common. And it can also be smoked. The effects are within minutes, but does last a couple hours, usually 5 to 6 hours. So what we'd expect to see in low dose, like I said, that's your stimulant effects. So you actually get tachycardia, hypertension. And the high doses, that's when you actually kind of get that reversal. You start hitting those opioid receptors. You got more hypotension and respiratory distress. So the positive effects that patients are looking for is going to be alertness, energy, and euphoria. And the negative effects they may experience are kind of that depressive crash once they start getting that downward spiral, the narcotic effects. So that's an interesting thing in this video that I'm going to show here. Initially, this gentleman's taking a normal dose. I think it's 2.5 to 5 grams. He's taking kind of what would be your normal dose, low dose, and he starts getting this amphetamine effect. So he's very stimulated. He's euphoric. He feels really good. He's happy. The world is his oyster. And then, of course, he decides to take a larger dose and kind of push the limits. And very soon after that, he starts going to this depressive crash. What you'd almost expect to see someone on if they're taking hydrocodone or a Percocet or something. So you can see throughout the rest of the video, he just kind of starts going down and just not feeling so well. And here the friend's describing how he had this high and has now crashed into a low. So again, that's kind of an interesting effect of the drug itself. And more interesting is that there are case reports of Kratom reversing with naloxone, given the fact that it has effects on those opioid receptors. And you could actually see patients who are in long-term Kratom use actually experiencing withdrawal syndromes once they actually come off the drug itself. So again, it's very interesting that it has that very similar effect to our opioids. So going back to the patient, the fact that he had this depressive state from a designer drug and then reversed with naloxone, it kind of gives us a high suspicion that Kratom may have been causing his issues. And I'll talk about this at the very end, but obviously there could be multiple different things on board. It's very, very, very common for patients coming in on these drugs to have multiple substances on board. So reversing the Kratom and then may then just expose another medication he has on board. It could expose the stimulant effects of the Kratom. It could also expose some amphetamines or bath salts that he may have in his system as well. So to wrap up, I just want to do a real quick dive into what to do with these patients when they come in, because especially your bath salt patients and some of your synthetic cannabinoids, they can come in pretty scary and combative and create an unsafe environment. And this can be a whole talk in and of itself, but I think it's important to have in the back of your head, hey, what should I do with these patients to protect myself, protect my staff, and protect the patient? And it's not so important that you know what the drug is, and there's not really many reversal agents for any of them, but just in general, how to control the situation. So we kind of take an A, B, C, D, E approach like we try to do with everything else in medicine. Obviously, our ABCs are going to be airway, breathing, circulation. It's very uncommon for these patients that they actually need to be intubated. With a large Kratom overdose, you can get obviously respiratory depression, but we do know naloxone may actually help. But the other ones, often the reason why they need airway protection is just because they're so violent and they are causing trouble with the workup and treatment. D is going to be de-escalation. So de-escalation, again, this is a whole talk in of itself. You can try the verbal de-escalation. We should obviously go through all of our steps that we can. But in these patients, they're in a different world. That's the reason many of them took this drug, is to leave this world and go to a different world that's either more enjoyable or at least detaches themselves from what's going on in this world. So verbal cues don't often work with them. So often, very often, we're going to have to take a chemical restraint approach. I'll just kind of go over my approach real quick. I'm a huge fan of ketamine. Anyone that works with me knows I love ketamine. I like it because it completely dissociates them from the rest of this world, and it decreases their drive to respond to what you're trying to do. Obviously, people may ask, well, if they're already high on methoxetamine, why would I want to give them more ketamine? Well, if they come in a combative state and they are conscious and fighting you, they're probably in a partial dissociation state. So what ketamine will do will then push them more into a full dissociation state and help control the situation. If you aren't comfortable with that, midazolam in most studies we've seen has really shown to be the quickest on, the quickest off, and the safest benzodiazepine that we can use in these patients. Can also be given IM, IN, and IV as well. So a good 5 to 10 milligrams of midazolam will go a long way. The next step is then what to do with these patients afterward. And I just wanted to bring up, I've had a lot of success lately with dexmedetomidine or Precedex, getting initial control with a ketamine or midazolam and starting a Precedex drip. I've liked this a lot because it's a very safe medication. If they start having negative effects, it turns off real fast. It also controls some of the side effects of these medications in terms of vital sign abnormalities. These patients may come in tachycardic at 180 and hypertensive at 220. And dexmedetomidine is essentially IV clonidine. So it actually has some very nice effects. It doesn't have much respiratory depression. Like I said, you can turn it off real fast and it runs out of the system in a couple of minutes. So that's been kind of my go-to. And then the E is going to be protect end organ damage. Like I said, there's not much you can do specifically for each drug, but we want to make sure we protect them from end organ damage. And the main ones we're going to worry about, the brain and the kidneys. These patients, the reason patients die in what some folks call excited delirium is mainly from hyperthermia. You start getting very high temperatures, and that's what actually kills patients, if not their airway compromise. So we may need to actively cool these patients, but hopefully just gaining control with your chemical restraint itself will actually start bringing the temperature down, but you may need to actively cool these patients. And also seizure precautions. We all know that the trifecta of death in toxicology, seizure, coma, death, but seizures are going to be a side effect of many of these medications as well. So actively protecting them from seizures or treating seizures with benzodiazepines or propofol or other medications. The other thing you'll commonly see is rhabdo. So again, these patients may have been in a throw of this drug for an hour or two, super hyperactive, moving all over the place, fighting people. They can come in with pretty impressive CKs. So make sure you're treating that, monitoring kidney function, and treating appropriately. And like I said before in the close up, just remembering multiple medications are usually on board with these patients. It's usually not, oh, I just took one bath salt. It's, I usually took bath salt, plus I was drinking all day, plus I was doing synthetic cannabinoids, plus. So just, you may uncover one thing, which then uncovers another thing. But just know it's usually not one substance that's causing these issues. So that's it. Again, this is the link to the handout. It has all the information I talked about. It has all the references I used, and also has my contact information. I hope everyone enjoyed this, and I will take any questions that you have.
That was really great, Andrew. It opened a whole new world of experiences out there that are waiting for me. I feel totally out of the sorts with none of this experience. You know, I never heard about the man who ate the other person's face, and so I think that's a story I need to hear.
Welcome to Florida.
Yeah, welcome to Florida indeed.
That was a great talk, Andrew. I think I have a new favorite talk so far for our conference. The bar has just been raised. That was a great set of slides and really concise, important information.
Let me ask you, with all these new things to choose from, are you still seeing a fair amount of cocaine and heroin in Jacksonville, or are we really seeing a trend toward newer highs?
It's funny because we've kind of taken this roller coaster ride. I mean, I'm 7 years out of training, relatively new, but when I was training 7 years ago, we were in the throes of synthetic cannabinoid and bath salt. That was the thing. And it was kind of fun. I remember talking to attendings at the time and realizing I hadn't really treated many actual heroin overdoses. To me, it was actually kind of rare that we really didn't have that many. In a lot of our patients, we have a very high use of cocaine, especially in the form of crack cocaine in our communities. That's always been pretty prevalent. But then we made the switch when Florida started cracking down, rightfully so, on narcotics and doing our narcotic databases, probably 4 or 5 years ago, we suddenly had a huge amount of heroin overdoses. And it seemed to us like, oh my God, this new thing that's happening in our community. But you talk to people who had been practicing 10, 15 years, it was just a resurgence. People had started with the bath salts and the synthetic cannabinoids and also the oral narcotics. And then cracking down the more, heroin had come back. Like I said before, we're not seeing bath salts as much as we did. We're not seeing the K2 spice synthetic cannabinoid. I think that is partially the fact that it's just not so easily obtained. I mean, you used to be able to get it from a gas station. But right now, the cocaine has always been here and will forever be here, unfortunately.